Yeah, it's a really important study, and in addition to the targeted therapies, there's been so much advances with immune therapies or therapies that kind of modulate the immune system to help the immune system work more effectively against fighting cancer. So, what's the impact of these immune oncology or immune checkpoint inhibitors and ATC?
Well, we're still figuring that out, but this is one of the earliest studies that we've seen. I don't think, anyone with a cancer diagnosis, you automatically hear the term immunotherapy. It's a hot topic, right? Well, what we found is if we only used immunotherapy alone in anaplastic thyroid cancer, we didn't see necessarily as good of a response as we would like. The overall response rate was 19%, and we actually saw over half the patients' best response be the tumor growing. Median overall survival was only slightly more than what we've historically seen. So the thought came, well, what if we combine them together, right? So we took immunotherapy and then added that to our BRAF and MEK inhibitors to see, does that work better? We knew we'd already made a good response or better than prior with BRAF and MEK inhibitors. Could we make it better? And we have two trials now showing that yes, we have prolonged overall survival if patients are treated with immunotherapy plus a BRAF and MEK inhibitor. So I pretty much have only focused on BRAF mutated thyroid cancer, but if you remember going back to that other slide, that only makes up around 40% of anaplastic thyroid cancer. We know that about a third of them are going to be driven by RAS mutations or other mutations that don't necessarily have a target. I would say this is an area of research we're all actively working on, and there's multiple clinical trials in this area. One thing that we've looked at is using something called lenvatinib, which is an oral chemotherapy pill that works regardless of the mutation that a patient has, and then adding that immunotherapy as well. We're still waiting on prospective trials to be formally published in this, but we've seen some real world analysis as well that's showing that when you add lenvatinib to pembrolizumab, you can end up having an overall response of around 36% and a median overall survival of 7.7 months. Again, this is an improvement from what we've seen historically. So recapping, for initial evaluation, we want to confirm the diagnosis of ATC, often with an ultrasound guided biopsy, whether that be an FNA or a repeat with a core. We'll go into staging and everything like that. Dr. Blumberg will take that on. We need the expedited assessment of our BRAF mutation with that IHC, and at the same time be sending out the tumor for additional analysis. Dr. Blumberg will also go into some of the other workup that we need in terms of what's going on in the neck. And then lastly, since I could speak for an entire hour just on the treatments that we could give for ATC, but realizing this is an area, there's a lot of research, making sure that clinical trials are being considered is really, really important from the patient perspective.
Well, thanks, Dr. Cubb. And one burning question that I had looking at the ROAR data was patients responded or did not respond regardless of their PD-L1 expression. So for patients who are thinking about maybe asking for immune therapy, how important is the PD-L1 expression and the number itself in terms of whether you give immune therapy or not?
So I think it's a great question and something we're still consistently trying to question. I will say anaplastic thyroid cancer, while we do expect PD-L1 expression, it's not as high as we see in other cancer types. So while it's something that we look at, I would not offer someone immunotherapy solely because the PD-L1 score was not robust.
Yeah, I agree with that.